I know that most of the colleagues in our floor, they are using different kind of fixation techniques. So I just want to actually focus on when I'm using the long construct and when I'm using the short one, and while using the short one, what I'm doing for reduction. I just want to focus on these important issues. This is one case, 41 years old, and as you can see that he got a L1 type B fracture, and together with the is a kind of we can say that this is a kind of unstable burst fracture. And of course, we may have some kind of options for this patient. I'm sure that most of you pick up one of these 5 options, which includes one level above, one level below fixation, one level below together with the putting the screw the fractured level, 2 levels above and below, ASF may be combined. All of these are our options. This is another patient, 21 years old. This is type C fracture dislocation, and she has a partial neurologic deficit. As you can see, that highly unstable fracture. I think she is lucky because of Asia D. Normally, I expect is more and more worse scenario for this kind of patients. Again, we have some options for this kind of patients, but how can we decide for our surgery? I would give some information about the history. As we all know that we started to, especially one level above and one level without putting the fractured level screw in early years, but McLean first author that published this paper, and there's a we may actually faced with this kind of failures with this short segment fixation, and then immediately after this publication, McCormack defined a classification in 1994, which is a load sharing classification, and he defined some domains, some spread of the fragments, then amount of the damaged vertebral body, amount of the corrected kyphosis, and then corrected traumatic kyphosis, and then he gives a kind of point, and then says, okay, you need to go for anterior for this point, and then you don't need to go for anterior. And actually, this is very important development for vertebral trauma surgery. And then, as you can see that smaller than 6 point, you can go for one level above and one level below surgery, and for the more than 6 point, you need to go for anterior column support. This picture is taken from his original article. But now, especially after the 2000s, actually we started to put screw the same level, especially if the patient doesn't have type C injury. And what is the logical behind this important thing? Because when you look at the traumas, more than 90% of the trauma, pedicles not broken, okay, they alive. And we started to put something like that, is shorter one screws, you see, very short, because we're afraid of putting the screw anterior part. But then we realized that this is not the case. And this is, maybe you know, this is Argenson technique. Is actually defined by this French surgeon in order to get for the short segment fixation. In order to get more anchor, he also put upgoing and downgoing hooks at the end in the same level, and keep mobile segments in the junctions. When you look at this article about a finite element model, comparing the putting the pedicle screw in the fractured level, you can see that this red, these are the von Mises colors. That means the concentration of the biomechanical stress. As you can see that biomechanical stress too much because the longer lever arm. If you put a screw fractured level, then you shorten the lever arm. It's a kind of anterior column support. It behaves like this. So that's why we are doing this surgeries now. This is actually the first time I did a small fellowship in Valdobron Hospital in Barcelona together with the Ferran Pellice. Ferran is originally a deformity surgeon, but he is also very good at trauma as well. Ferran defined this technique to me during that time. He's putting pedicle screws, but monoaxial, okay, not polyaxial, because you need to reduce your fracture. So if you have a ball and socket shaft and a screw head, you cannot reduce your fracture. If you apply the reduction maneuver, then it's kinking from this ball and socket part. So that's why you need to use monoaxial pedicle screws. And another important point, you need to be parallel to the end plates, because when you are putting your rods, okay, it's spontaneously reducing. When you are tightening your screws, it's reducing your end plates. And you need to put pedicle screw as much as long, because you need to take this and elevate the end plate. Just like the tibial fracture. We are using, during the tibial fractures, we are using screws parallel to the tibial plateau in order to elevate it. The same thing. And then you don't need to do any maneuver during that time if the patient have a fresh fracture. But interestingly, this is my observation, this is not written in literature, 1 week or 10 weeks after the trauma, so difficult to achieve this reduction in these patients, because there's a soft callus inside of the vertebral body, and it prevents your reduction. Okay? This is Ferran's, and Ferran actually published this paper in 2014 in Spine Journal, which defines his technique. This is 32 years old lady, suffers from the traffic accident without neurology. You can see that there's a fracture. We can say that is a type A4 fracture. Looks like is a stable burst fracture, we can say. And then, as you can see that the same technique with the pedicle screws, but monoaxial, I achieved the reduction of this particular patient. And there are some evidence about this one. When you look at the thoracolumbar burst fracture, there are 23 studies. This is Global Spine Journal published in this review article. And short and long constructs have similar results in terms of the outcome, clinical and X-ray results. So we don't need to go for long constructs for actually burst fractures. What about the kyphosis correction? This is another one in neurosurgery journal, published in 2015. If you put pedicle screw in the fractured level, you may get more kyphosis correction in this particular patient. But in this paper, they have some problems in terms of the inclusion and exclusion criteria. They have very heterogeneous group of etiologies. Another technique for short construct, especially I am using this one in the lumbar part, because let's say if you have a L3 fracture, you need to go for L4-5 if the fracture is type C, L4-5 and L2-1. This is almost all lumbar area is already fixed, which is not good for young patient. And what I am doing for this kind of patient, using the short construct together with the anterior spine fusion. I'm putting a anterior column support, but one level above, one level below at the back. Then I can save 2 discs, which is very important for lumbar mobility. Okay, when I need long construct, especially in thoracic spine or thoracolumbar spine, if patient have multi-level fractures, or if the patient have highly unstable fractures, and then I would go for long constructs, 2 level above and 2 level below. Coming back to our 2 first cases, this one treated with the pedicle screw at the fractured side too. This one, the first case. The second case, treated long construct. You can see that then she actually, her neurology is improved to the Asia E, and is her last in her last follow-up. In summary, short constructs is enough in most of the patient, and screw placement should be done in the fractured level. Long screw for levering end plate during that time, and early surgery for better correction. Otherwise, we cannot correct. Long constructs for fracture dislocation and multi-level fractures, and sometimes we need to consider anterior and posterior combined surgeries for shorter, having shorter constructs. Thank you very much for your attention.
Thank you. You didn't mention about too much. I would like to get your opinion about the decompression. If there is burst fracture narrowing the canal but no neurology, how do you manage?
No, I never do decompression these cases. Never. This is actually not my my personal opinion. This is universally accepted by all of the spinal trauma actually surgeons.
What about a case with 70% canal compromise
Again, because you know, during the trauma, probably this 70% is not at the actually minute of the trauma. It's probably 100 or 90% compression because of the viscoelasticity of the spine. It's coming back. Okay, it's like this, like hammer. It's going back and then come back, okay, like this. All of the fractures like that. So it's already decompressed to 70%. If patient didn't have any neurology during the 90 or 100% compression, and I assume that he doesn't have any neurology with the 70%. This is my actually
if there's no neurological finding, you don't
never, because I try to protect the lamina at the back for sometimes fusion, especially for high energy trauma. We need this part. Otherwise, we cannot do. Otherwise, we need to go to anterior and put some anterior column support in order to get fusion. And then our construct have a possibility of fail in the future because not having a fusion and no lamina and no anterior column support is like this, you know, it's totally unstable.
Okay. Yes, one or two comment or question.
The monoaxial that you put for the upper and lower, but in the fracture level, put polyaxial because you could move it easier to put the rod. You can put monoaxial in the fracture.
You mentioned the lining of the lining of the screw,
yes,
alignment.
Yes. Put monoaxial in the middle or in the fracture level. Put polyaxial. That's what we do. We found it more easy to put the rod.
Okay.
And the way that to put the screw, the first one, the proximal one, more to the end blade. The other one is more towards the body. By this, you could do better corrections.
I see. Okay, you can do something like that, but I prefer to put again monoaxial at the fractured level, parallel to the end plate. Maybe one more, let's say above, but distal polyaxial. This is more effective for reduction. I think just my actually how to say, my thought. This is not a evidence or nothing. Just for discussing.
Yannis have a question.
I have an observation and a question. The first is that because I am treating these kind of fractures, usually MIS, I cannot use monosegmental, usually we must be polyaxial, but we use the bed for reduction. And the second is, what is your opinion for anterior support to use something like kyphoplasty?
Okay, actually, if you are using for this first case, of course, this is one of the way. Actually, I appreciate your comment. The second one, if you are using, especially young age, if you are using some kind of bioactive bone cement, calcium phosphate cement or something like that, okay, it's good idea. But if you are putting polymethyl methacrylate, PMMA, to the anterior part within the fracture, this is a chemical polymer, and you cannot achieve any kind of healing in the anterior column of the fracture. This is my actually thought. So I never try. I never put it is a young age, high energy trauma. I never put a PMMA the anterior part. But you can use the inflatable balloons of kyphoplasty in order to get reduction. Otherwise, you don't need to put something actually anterior column. If you would like to put PMMI, I think we should avoid this one.
Yes, Misochi.
Sorry?
In the elderly?
In elderly, yes, of course, we can do, yeah. In young age, we should avoid.
Congratulations, beautiful
Thank
presentation. Just a suggestion. When you have a burst fracture, do you suggest 100% to decompress by anterior retroperitoneal, transperitoneal approach and then reconstruct the vertebral body, or could be enough by the same posterior approach just to remove bilaterally the chips, bone chips, and then stop? What is your opinion about this second option?
If the patient doesn't have a kind of neurology, I never go to anterior part. It causes bleeding, especially in acute fractures. So I'm afraid of this bleeding as well, because it's not easy to go from the back to anterior part under the bleeding. As I mentioned before, if there is no neurology, I never touch anterior. But I know the German way, Germans always goes to, because they think that the disc fragment is going into the fracture and then is cause pseudoarthrosis. But there is no, strong evidence in the literature. When you look at the literature, there is no strong evidence about this this thought. So that's why I never goes to anterior, because this is a fracture, and we need to mobilize the patient as soon as possible. No way to go anterior and posterior. This big surgeries. These are big surgeries.
No, that was a very beautiful presentation. I really, agree with whatever you have said. I have one question. Suppose a patient is paraplegic.
Yeah.
Do you change your strategy?
Yeah,
Suppose the
I need to do, especially partial neurologic deficit. I always do decompression as soon as possible. And for the paraplegic patient, I try to do as soon as possible, but there is no evidence when you look at the literature if it's a spinal cord level, if you are doing this as soon as possible. But I always try to do this one, because I also convinced that the patient and relatives that I'm doing everything that I can.
No, my question is, whether in a paraplegic patient you will do a long construct or a short construct.
It's again depends if the paraplegic, generally paraplegic coming from thoracic side, so we don't need to actually save the mobile segments. So we can do long construct in order to have the better rehabilitation as well, because sometimes they may get more shear forces during their rehabilitation and during long walking devices, other things, so on. So they need more strong, support at the back.
Yeah, you know what? Your strategy is all right for small fractures with marginal deficits. But for serious deficits or like paraplegia, I think either don't do operation, but if you are doing, long constructs may be better.
I agree with you.
Dr. Zileli has a comment.
Yeah, very nice overview of thoracolumbar fractures. Actually, the question is if there is a burst fracture and no neurology, what to do? So, if there is some kyphosis and if there is more than 50% height loss, then we should try to make a fixation in order to prevent further kyphosis. Or in the future, we expect with those patients a deformity may develop. But our aim of surgery is mostly not a prevention of the spinal cord. It's mostly not. But if there is any neurology, we must do very nice decompression together with